Welcome to 502 Conversations. I'm Brian Kirby, and my guest today is Dr. Christopher Labos once again. Dr. Labos, how are you doing up north in Montreal?
It is very snowy and very cold up here, but otherwise I am quite well, thank you.
Oh, it's very snowy. Interesting. I must say, I guess I showed a bit of bias there. I'm south of you, so I said, welcome up north. For all I know, there's someone farther north than you thinking, what's he talking about? Montreal is south of me. All right, let me give you a proper introduction. Dr. Labos is a cardiologist with a degree in epidemiology. He writes for the Montreal Gazette, makes regular appearances on CBC radio and TV, and is host of the Body of Evidence podcast, where he takes a skeptical eye at health claims and looks at the body of evidence on a variety of health topics. He is also a course lecturer in the Department of Epidemiology, Biostatistics, and Occupational Health at McGill University. He is an author of the book, Does Coffee Cause Cancer? And 8 More Myths About the Food We Eat. I like to have you on once a year to do a cardiology year in review, but this episode's a little bit different. I reached out months ago because of an episode of Body of Evidence about cannabis and medical use, and I wanted to discuss that with you. And now, this was back in May, as we just confirmed. No, was it April? April, as we just confirmed, which was, I don't even know, 7 months ago. So we're just getting to it now. Mostly my fault for the delay. I dropped the ball, but I must say you got married in that time. You traveled the world, so you've been kind of busy too, right?
A little bit.
How is married life treating you, or should you say? I'm sure it's great.
It's great. I highly recommend it. I don't think you should buy a house and get married in the same year as we did, but that was a lot. But I highly recommend married life to all the unmarried people out there.
All right. Well, at least you didn't buy a house, get married, and do a complete remodel on the house, right? That would be
weird. No, it was pretty turnkey, which was a saving grace, I have to say.
And what observational studies show that married people live longer? Is that right?
Yeah, they kind of do. They really do. You know, it's important to have somebody to grow old with. It helps.
Okay. So if you're not married, Dr. Labos is recommending get on top of it.
Yeah.
Okay. Now to the cannabis episode. This is unusual. Usually I'll ask you a question, then I'll be quiet while you talk. But if you don't mind, I've got some stuff to say up front. Okay. Mm-hmm. But you can interrupt as we go along. And don't feel, just say, listen, that's not, if you want. Basically, this cannabis episode you did, I thought it was just a little bit over-optimistic about the benefits of cannabis. I've done several cannabis segments on a show I co-host with a preventive medicine doctor, but usually we're pointing out all of the harms that seem to be associated with cannabis use. Heads up, I did vote for recreational legalization, but now I kind of regret it. And until recently, maybe a year or 18 months ago, I was still holding out for benefit for nausea and anorexia caused by chemotherapy. But now I don't even know if that appears to be correct, or it might be of low evidence. And again, don't beat up on me too hard here because I'm way out of my league questioning you. Feel free to interrupt as we go. Now, one thing that came up that may have been a bit confusing for me is in the episode, you mentioned purified THC for seizures and multiple sclerosis, but it kind of bounced between that term and medical marijuana or cannabis was the term I think used most of the time. So that made me just generally think of cannabis and all the products and the claims and the corner stores. I don't know what's going on up in Canada, but we've got billboards abounding and ads that it's like every other supplement in the world. It cures everything, or it can cure everything. And so I understand the specific uses for synthetically manufactured cannabinoid. It's dose reliable, right? It's specific dosage, like for chemo-induced nausea. What's it called? Nabilone?
Yeah.
Is that it? For that, and also for off-label for chronic pain and MS. And then there's some kind of purified CBD for certain types of seizures. But again, I think when people hear medical cannabis, I think that's a more general term than specific, or at least that's what I heard, what I hear.
Yeah.
I don't know. Do you have any comments on that first?
Well, yeah, so here's the problem. I mean, nomenclature does matter, and I think it's why it's important to sort of clarify all this. So let's start at the beginning. The plant is called cannabis. So cannabis is the genus name. The species names are Cannabis sativa, there's Cannabis indica, there's Cannabis ruderalis. And when we speak about it medically, the preferred term to use is cannabis. Because marijuana, where that name comes from, is actually a little bit unclear, but it was really popularized during the 1930s during the anti-drug campaigns where people were trying to get marijuana outlawed and, succeeded in getting it outlawed, specifically in the US. It has some negative connotations, it has some ethnic connotations, and so there's been a feeling in the medical community, at least, that when we're going to talk about it scientifically, we shouldn't use the term marijuana, we should use the term cannabis, because marijuana, weed, pot, these are all sort of nicknames that have no scientific or medical meaning. So we talk about cannabis. Just as an aside, when you're talking about hemp, you're talking about a specific type of cannabis plant that has very low THC levels in it. And that's the stuff that's used in textiles. It's not used for, recreational drugs in any way. So cannabis is the plant. Inside this plant, there are hundreds of different chemicals. The two big ones are THC, which is tetrahydrocannabinol. THC, that is the one that tends to have the more psychoactive effects. So that's the one that's going to make you high, essentially. And then there's CBD, which is cannabidiol, which is used and has been used in many medical situations. In a very, very broad sense, people used to say that THC was the stuff that was used for recreational drugs. CBD is the one that has medical applications. It's not quite that clear cut, and you do see THC used as well in certain medical settings. And this comes to the first point, is that if you're going to use the product of this plant for medicine, the trials that have been done, especially the seizure ones, you are not giving people a plant and telling them, consume this plant in whatever way you want. You're not telling them, here, smoke this plant or bake it into a brownie. You are giving them a fixed dose of an active ingredient, and whether that's CBD or whether that's some of the other synthetic cannabinoids that are out there, you are essentially deriving a medication from the plant and using it in a controlled clinical trial. Not dissimilar from what aspirin is, right? Aspirin, you take the bark of the willow tree, you extract salicylic acid, you add an acetyl group to it, you get acetylsalicylic acid, and now you have aspirin, which we use to treat heart attacks. There are a number of clinical trials that have used synthetic cannabinoids. And then there's a whole bunch of research that has looked at people using other forms of cannabis, whether it's smoked or whether it's recreational use, often based on self-reports. And so the quality of the research is very broad. It's sometimes hard to pull it all together. And one of the big limitations has been that because cannabis was illegal up until very recently, it was not easy to do research using cannabis or synthetic cannabinoids. And so that lack of data has left us with a lot of uncertainty. So if people want to go back and listen to the episode, it was me interviewing another physician here in Montreal, Dr. Mark Ware, who has done a lot of work in this. And yes, to be fair, he is a proponent of this. This is his field of research. So he believes that cannabis, medical cannabis, can be used in a number of different settings. We have a bit of a debate there. I think you can use it. And what's going to come out of this, and we're probably going to end up repeating this multiple times over the course of the episode, is that the quality of the evidence is better for some cases, less good for other cases. The solution to that is get better evidence, obviously, like do the clinical trials, invest in the research. But also, we have to decide as a society, how much evidence do we need before we start using this product to treat something? So if you're going to be using cannabis in a palliative care setting to treat somebody with chronic pain, do you really need to do a randomized controlled trial on this with like 50,000 people over 10 years? Because you are in a palliative care setting, you can just try it and see if the patient feels better or not. When you are treating symptoms, you have a much more immediate feedback loop in terms of, is this thing being effective or not? So money is not infinite. Research funding is not infinite. We need to decide where the research dollars need to be spent. So if you're going to investigate this as a treatment for a pediatric seizure disorder, then you want very clear evidence before you start giving these types of synthetic cannabinoids to babies, essentially. Whereas when you're talking about a palliative care setting, maybe it's not as important for the data to be as rigorous. So we need to have that in our minds that, you can't do randomized controlled trials for every conceivable situation. Sometimes you have to make do with the evidence that you have.
Okay, great. Thanks for laying that out there. And so also if some of this is from memory, of course, but I have looked at it more recently. So if I mischaracterize something, just say so. All right.
Yeah.
Especially because I don't want to say something that's inaccurate. So I'll approach this from a hypothesis standpoint, I guess. So I have two claims that I need to support. All right.
Yeah.
So the first is that, don't take this personally because it's not personal, but I think at the time of the episode, and again, I may have misunderstood some of it, I think there were some studies available that might have tempered some of the enthusiasm because it's, again, it kind of bounced back and forth. So you just defined cannabis versus CBD, so that's great, versus the... So we're saying cannabis, but people still think the cannabis store down the street, I think, and everything that goes along with it. So that's just an issue, I guess, of we hear what we want to hear, I suppose. Okay?
Yeah.
So
yeah.
You just mentioned the studies and the clinical trials. So as you are epidemiologists, let's just start right there. So define for me, so just give me some limitations of these observational studies that we sent back and forth to each other. And then also, what's an example of an observational study that was good enough, or convergence where you just said, okay, we don't need an RCT. We know this is bad.
Yeah, so here's the thing. The issues with the observational research is, so first off, if you're going to do a study where you're questioning people about their intake of cannabis to try to see if it's associated with any specific disease, how are you going to collect that information? That is the big limitation there is the same thing that we see with food science. You're trying to get people to accurately report the consumption of a product that can vary and change over time. So are you going to just ask people, do you use cannabis, yes or no? Are you going to try to quantify the dose that they take on a weekly or monthly basis? And then how reliable is that reporting? If somebody says they smoke cannabis every day, then you're like, okay, well, that's pretty clear that they're smoking it a lot. But if somebody says they only smoke cannabis once a month, how do you characterize that? And are you sure it's once a month? Is it possible that people are underreporting their cannabis consumption because there's still a bit of a stigma about it, right? Especially when it's illegal. If you were going to ask people, do you smoke cannabis? Were people going to say no when they actually did? So there's a real problem that the information that you are getting back from people in order to analyze your data it's by its very nature inaccurate. And there's a name for that in epidemiology. It's called information bias. Basically, that the way in that we are collecting the data leads to bias because it is fundamentally inaccurate. And it's not that people are lying per se, but there's human nature is that you tend to underreport what you're actually doing. And we see this with smoking, right? Because people don't want to admit that they are smoking because they know that there's a certain social desirability bias against smoking. People tend to report that they smoke less than they actually do. When you ask people, people claim that they are taller than they actually are. People tend to report that they weigh less than they actually do. So unless you have a way of actually measuring cannabis consumption, which is very difficult to do practically unless you're directly observing people, the information you're getting back is going to be limited and prone to this type of bias or confounding. And so this is a problem with all observational research. It's not limited to cannabis consumption, but it is an issue. And so you have to look at all of these studies and realize that maybe people are not being labeled properly. Maybe the people who don't use cannabis actually, or the people who say that they don't use cannabis actually do. So this is problematic. Mathematically, when you have this sort of bleed through where people can be in one camp versus the other, it would actually tend to bias things towards the null, meaning that it would make it seem as if there was no difference when in fact there is. So if you see a difference in this type of observational study, even though people are actually using cannabis when they say that they're not, it tends to suggest that it probably is a true effect that you're seeing there. So I think the nausea thing, especially after chemotherapy, like, the treatment of chemotherapy-induced nausea, is an interesting example where the data is maybe not as robust as we would like it to be. Like, it would be great if there was, a multinational 40,000 person randomized controlled trial on this. There are smaller studies, there's some observational data, and it was good enough for the FDA to grant approval for 2 synthetic THC agents, dronabinol and nabilone, which are used. And the advantage of saying good enough for chemotherapy-induced nausea, I mean, either you're going to feel better or you won't, right? If you take it and it doesn't work, well, then you know very quickly that it doesn't work. It doesn't make you feel better. You can set it aside. Why you would need more stringent data with something like cardiovascular disease, if you're trying to prevent a heart attack 10 years out, you're not going to know that you're not going to feel better as a person taking this supplement or that supplement or this blood pressure medication or this cholesterol medication. So you need much more rigorous data when you're trying to prevent long-term hard endpoints. Whereas when you're trying to treat symptoms right now, you can really just try and see. And then in a cancer situation, especially when you're talking about palliative cancers, sometimes you just try stuff because you just can't have a randomized control trial for that particular situation. So I think the nausea thing is one of those situations where, yeah, it does seem to do something, and we're probably good enough that it would be great to have the trial, but it's maybe not the highest priority in terms of research funding, writ large.
And in that specific case, again, you're talking about an approved medication. It's dose specific. It's synthetically manufactured, so you know what you're getting.
Yeah, the issue and the challenge with smoking or edibles or all that other stuff is that you do have to be a little bit worried about the dose because the dose is not standardized. I mean, there is a reason why most of the clinical trials are using fixed dose medications because it's standardized. You can do it in a clinical trial. When you smoke something or vape something, you are getting a much faster absorption, and that is appealing to some people who want to get the medication, who want to get the product into their system very, very quickly to get the effects very quickly. But, how much is going to be absorbed by your lungs? How much, if you have underlying lung disease, is that going to impair absorption? There's a lot more variables. And so to do a clinical trial with an inhaled medication is going to be much harder. And so, it is a bit challenging because if we're going to practice true evidence-based medicine, then we have to go with the evidence that we have. You have to realize that there is going to be a lot of variability with other routes of administration. That doesn't mean it's wrong, but you have to understand the inherent limitations there and realize that you are now deviating from a protocol. That doesn't mean you can't deviate from protocols. It just means you have to understand what it is that you're doing.
I want to talk some things that came up in general to defend my claim about the evidence here. I'm not accusing anybody of deception. When you're bantering a conversation back and forth and you don't have papers, it's not like that at all. Again, with the nausea and the cannabis and the dose specific, just briefly, I will tell you that I did not realize that. So if you go to your supermarket and you buy a Snickers bar or something, that's a candy bar you eat, right? I didn't realize that if you go buy a marijuana or THC candy bar, it's a candy bar, but it's actually 4 servings. So when people think a candy bar or a cookie, they think, oh, I'm going to eat a cookie. I'm going to eat a candy bar. They're not going to look at the back and say, this is 4 servings. That may come up later in the overdose. But anyway, so let me counter some stuff that came up. And I think that it came up that there was concern that pre-legalization, there was concern about effects on the developing brain, on driving, on mental health issues, school performance, youth use, public health and safety, lung issues if recreational cannabis became legalized. Those are things that Dr. Ware said they were worried about. And then he said, by and large, we haven't seen increases in youth use. We haven't seen carnage on the roads. We haven't seen epidemics of psychosis or issues around toxicology and overdose risks. And if we do, it's mislabeling, it's misunderstanding, it's irresponsible handling of the products. That's kind of what I just said here. Okay, so that kind of paraphrases what he said on the optimism about we didn't see this carnage, right? All right, so I'm going to counter that. He's not here to defend himself. I'm not accusing him of any deception or malfeasance. Just, be aware of that. So, but at the time of the recording, I think there were studies that showed increased emergency. In fact, I know there were because of the dates on them that showed increased emergency department visits due to cannabis use and driving accidents and injuries, specifically one out of Canada. There were papers on cannabis-related psychosis. There were studies on increased use in young people in Canada. All right, maybe it's flat here in the U.S., but older adult use is up, and studies do show an increase in visits to the emergency department due to overdose. There's this crazy screaming nausea ED visits related to hyperemesis They increased from 2 to 3 times a month to daily, or depending on the time period, they went from daily to 5 times a day, depending on the time period study. So we're not going to talk about all those studies. I know I did a bit of a gish gallop on you, but I do think those studies did exist. I can link them in the notes. We're going to zoom in on some cardiovascular disease and GI issues later, but any comments on that part? So that's my first claim and some support for it.
So you're right. Anytime you legalize a product, you are going to see more use to some degree. Now, how much of it is a true increase and how much of it is people just reporting what they were previously hiding, right? Because before legalization, people are like, no, I don't use cannabis. And then after legalization, people are much more willing about it. So you're always going to see an increase. The real test is going to be 10, 20 years from now, does it level out or does it keep going up? So there's definitely been an increase, that's true. And the minute you make something more accessible and more open, you are going to see more overdoses. I think the point that Mark Ware was trying to make was that we haven't seen, reefer madness in this country, right? You have a decriminalization, a legalization of cannabis. The people who are not going to smoke cannabis are not going to smoke cannabis. The people who do want to enjoy cannabis are going to go off and do it. And there hasn't been, an unraveling of civil society. But there are issues and there are safety issues here. And that's absolutely true. And we can talk about it. And I'll tell you one example of a particularly bad situation that has exposed, I think, a weakness in the legislation and the regulation. So about 2 Halloweens ago, there was an episode in Winnipeg and then a very similar one, I think, in Vancouver, where this couple, I think it was a couple, they were handing out 2 kids who were coming trick-or-treating bags of edibles, like marijuana edibles, made to look like candy. Now, whatever your position on this issue is, I think we can all agree you shouldn't give 2 children adult doses of edible cannabis labeled to look like candy. I mean, this is sort of like the equivalent of the Tide Pod thing, right? Where kids would see Tide Pods or detergent pods, think they were candy because they were brightly colored and all that, and they were packaged individually. So they were handing this out. Parents noticed. They called the police, and the police had to go to these people's house and say, please stop what you are doing. What you are doing is illegal. And what these people had done is that they had ordered these edible cannabis gummies online and, shipped them to Canada. And they were actually in frank violation of the packaging rules because they were deliberately packaged to look like a common candy brand. I forget which one right now. I think it was Nerds maybe, but I don't know. But I think we can all agree that if you're going to sell cannabis at a store, whether it's a government dispensary or, a private commercial entity, it should be very clear from the packaging that it is cannabis, not candy for kids, right? I don't think there's any controversy on this issue. So there are definitely safety issues that need to be addressed, but they are around legislation, regulation. How do you deal with people ordering stuff illegally off the internet, right? These are important legal issues. If you're going to take it from the purely scientific standpoint, we haven't seen a huge increase, but there has been an increase. I want to tell you about one study with regarding to driving safety. So I wrote an article about this for the Montreal Gazette.
Okay, I will. Let me throw an anecdote in there too, because a friend of mine, I know anecdotes aren't science, but a friend of mine, it's kind of a similar thing in adults sometimes. His mother-in-law was visiting. There was a cannabis chocolate bar out. She likes chocolate. She ate it unknowingly. Boom, ER. I mean, because she ate the whole thing, right? She's fine, but it's not. We'll get to the societal cost later. But and the driving thing, I think that because that can be coded once there's an accident. Speaking of observational studies and collecting data, driving accidents can be coded medically, right? So if there's an injury due to an accident, you show up at the hospital, you've been ingesting cannabis, that gets a code. They're more likely to have an injury or be transferred to the ICU or something. Yeah. So anyway, I don't know if that's what you're talking about. I think that study was specifically out of cannabis with so if we speak, 4.5 times increase, which is 450%, as the news people would say. Anyway, I digressed. Back to you.
Okay, so here's the thing. So people can find this article that I wrote. It was from the Montreal Gazette. Just look for Christopher Labos, Cannabis. It's going to come up. So you're right. Cannabis is an issue with regard to car accidents because cannabis is often the second most common drug involved in car accidents after alcohol, right? The problem is that out in the real world, when people get into a car accident intoxicated, they often test positive for both alcohol and cannabis at the same time. So which one was responsible, or were they both responsible? The other problem with cannabis is that the blood levels of THC, the chemical tetrahydrocannabinol, do not necessarily correlate with the degree of intoxication in the same way that alcohol does. So it's very hard to be sure how much the THC was responsible. So there was this study, I think out of Australia, and it was really interesting. So what they did was they took 26 healthy volunteers and they randomized them to vape THC or CBD or a THC CBD mix. And then they had them do a driving test after 40 minutes and 4 hours. Now, the remarkable thing about this study is that I am shocked this got through ethics approval, because you would think they did the driving test in like a closed course, right? To have them like drive between cones. And no, they did this test on the open highway.
I thought you meant a simulator.
No, they were driving on the highway in a real car. So this was a shocking study that this got approved. Now, to be fair,
Wow.
the volunteers had the presence of mind to pull back when they said, I can't drive. And so a fairly large number of them did not do the test at specific times because they said, I'm too high to drive. But for those who did complete it, there was no difference in driving capacity at 4 hours because the vaping had left their system. But at the 40-minute mark, there was more swerving in the times when people vaped THC or the THC and CBD mix. So I think it's interesting, as far as, there's not many randomized controlled trials in this field. So I think it's very clear to say that cannabis, when you smoke or vape cannabis, it is going to affect your ability to drive. And the fact that you have CBD in there is not going to negate the effects of the THC. So we have to look at cannabis in the same way that we look at alcohol. It does impair your ability to drive a car. You should not partake of this substance and then go and drive a car afterwards. It is dangerous. And in the same way that we have laws against drunk driving, we need to have laws against high driving. The issue here, though, is that if you're going to use this as a justification to ban or restrict cannabis use, well, then why wouldn't you ban or restrict alcohol use, right? Because alcohol is also detrimental. So it becomes a question of, are we going to treat cannabis differently from alcohol? And, more and more, I think we're seeing it as a substance that probably, at the very least needs to be decriminalized, but it should be taxed, regulated. You shouldn't sell it to minors, right? All of the stuff that we mentioned. And then we need to have laws about people using it before they drive. The difficulty with cannabis is that you can do a roadside test for alcohol, right? A breathalyzer test. You can't really do the same thing for cannabis. And so the police and the regulations have not caught up to the point where it's easy to test for this. People have to use their judgment, bring somebody in, and then actually test them to see if they've been smoking cannabis. So you are correct in that this is an issue. It becomes the question now, yes, it impairs your ability to drive a car, but does that mean we can't also use it medically in certain situations? And I think that's how we have to think about it in this almost very divided framework.
Yeah, divided, like you had said, willow bark versus aspirin, or foxglove versus digoxin?
Okay. Yeah, digoxin,
nobody talks
exactly.
about foxglove, right?
No,
nobody's out there at the foxglove corner store. But
I wonder, I'm sure there's somebody on some dark corner of the internet trying to sell you foxglove. But that's the thing, is like, we can use these products medically, and I think that's where we have to separate it, because there's a legal regulatory argument that has to be had, but there's a medical scientific argument. And so we have to be clear about which argument we are having. And we frankly need to have both, because there's a lot of regulatory changes that need to happen, but there's a lot more medical scientific research that has to get done.
And I just want to talk about cannabis versus alcohol for a second here. What happened when cannabis became legalized is we have corner stores everywhere now. We have billboards. We have ads on TV making outrageous claims. I went to one of the cannabis store websites because they have a tab on education. So I'm thinking, okay, here's the responsible part. You're going to read this. It's going to tell you to be careful and consult your doctor and don't, use with caution. No, it was all education about what kind of bong to buy, what kind of edible. It was totally out of it. So my point here is that I'm not for reversing the legalization. I'm for a massive amount of education. Like, there's no good use for recreational use, like there's really no good use for alcohol. We don't see the alcohol store owners broadcasting how great this is and how it treats everything. It treats sleep, insomnia. So there's the difference, or a difference, I should say.
Yeah, I think we've avoided a lot of that here in Canada because here you go out and you buy cannabis at a liquor, like the equivalent of a liquor store. So we have specific dispensaries that are run by the government. So you do remove that sort of commercial advertising aspect from it. So I think that is a good way to do it because you do need regulation on on the side of marketing, because the minute you allow marketing, people start making claims that are not supported by evidence.
That might be a feather in your cap there because you are in Canada, so the regulation is different, but you've got to realize you have a worldwide audience now, right, with your podcast. So when you're talking about this stuff, I'm hearing it down here, and I'm looking around. This guy's crazy. Look what's going on. No, that's not what I said, but I'm just saying, look at all of what's going on down here. So now it makes a little bit more sense as well.
Yeah. And you do see advertising, you do see signs and all that, but the fact that it's like at specific dispensaries does make it a little bit more regulated. And I think that's what it comes down to. If we're going to treat cannabis in the same way that we treat alcohol, you treat it the way you do it. You sell it at, the equivalent of a liquor commission. You have restrictions about not selling it to minors. You have laws about not consuming this product and then driving. All the stuff that frankly is common sense, but you have to do it. And the legislation has to catch up with the reality, which I think was a lot of the problem up until now. Cannabis was just illegal across the board. And then as states started decriminalizing and legalizing it, the regulatory mechanisms were just not put in place fast enough to keep up with, the actual demand.
Yeah, and just a couple of days ago here in Massachusetts, the Cannabis Commission, or whatever that state organization is that gives out these licenses for the corner stores to open up, now they've approved cannabis cafes, right? Like coffee shops and stuff. You still have to approve it at the town level. Incredibly bad idea. I know they're just chasing tax dollars. We'll talk about that maybe later. Okay, so it did come up in the evidence, and you mentioned it it did come up in the episode that it's hard to convince the manufacturers to invest in large studies because of, the standardization issues of the plant, like you said. But I'm a bit skeptical of that reasoning, and I think that I'll tell you why. I think that perhaps because the observational studies are showing more risk than benefit, at least that's what I'm seeing. Why would a manufacturer want to do an RCT? Like supplements, the anecdotes, the testimonials, these ads, the popular belief is selling the product. Why do an expensive RCT that you're only going to bury like the tobacco manufacturers did, right?
Yeah. Well, here's the problem. The same sort of thing, drug companies have to do randomized controlled trials to get approval for sales, right? So I think this problem is very similar to the problem that we have with a lot of the pharmaceutical companies, right? There is no incentive for the pharmaceutical companies to do these clinical trials on their own. We required it of them for marketing, right? For them to be able to sell the product for approval. So if we're going to rely on private industry to do these trials, it's not going to happen. It has to be driven by academic researchers, and that requires funding. So if you're somebody who says, I want large randomized controlled trials on this issue, well, we're going to have to fund it. We're not going to be able to rely. We can't just expect the private companies to do this on their own. They have no incentive to do so. They're already selling their product. So that is a fair criticism. It just reflects the importance of having academic funded research that is not dependent on industry funding.
Yeah, well, what's going on down here with grant money and so we won't go there. Okay. All right. So that kind of wraps up my first claim. The second claim that I have is I think there is actually more. Well, again, I'm talking about the popular use of it because I think you're saying medical cannabis and you guys are doctors and you know about these specific dosage, but that gets taken out of context like crazy down here.
Yeah.
So contrary to popular, so my second claim is that there's more harm than benefit.
Yeah.
And contrary to popular legislative belief, it's just including the benefit from the sales tax revenue. I just think there's more harm, and that the enthusiasm, the advertising, and the use, it just outweighs the evidence for the medical use of over-the-counter cannabis, which is what we're being sold on here. One thing I did want to talk about was the societal costs of legalized cannabis, right? And some of these do overlap with my first claim, but you have the increased emergency department visits. You've got the addiction treatment for the uninsured. You've got the victims of the drug driving accidents and the visits You've got, I think, primary care doctors are seeing visits for breathing problems due to inhalation, including asthma and upper respiratory. And there are some psychiatric needs increased with the pediatric patients with issues related to marijuana. We did talk about the accidental overdoses. There is some psychotic-like symptoms maybe in those that are more vulnerable. Those are all societal costs. And I also think that when I look this up, it's hard to get this information because it varies by state, of course. So, but poison control exposure cases for kids 9 and under increased like 5 times in Colorado after legalization, right? We've seen workplace injuries rise with employees who screen positive. But I think one of the bigger things was that, I think this came out of Colorado again, was that for every dollar gained in tax revenue, they spent like $4.50 to mitigate the effects of legalization. So there's just all that. I consider those societal harms that we're going to have to pay for. And like with tobacco, right? Tobacco revenue is $891 billion a year, and they pay out $9 billion in taxes, which doesn't even come close to the societal harm.
Yeah, it really comes down to how you want to approach this issue because, exactly as you said with tobacco, the harms outweigh any type of economic benefits that come out of taxing tobacco products. And so we have, over the course of many decades, tried to implement anti-smoking legislation, which frankly, by and large, has worked and has decreased the amount of tobacco. But if you try to make tobacco completely illegal, I think we know what's going to happen. We saw what happened during Prohibition. Like alcohol, I think if you were honest about it, you would say it's a net negative for society when you consider all the times when it's involved in car accidents and domestic abuse cases. Like alcohol is a net negative for society as much as many of us may enjoy drinking it. But if you try to ban it, you end up creating organized crime, you drive it under the table, you lose the tax revenues from it. It's a very difficult thing. So on the one hand, you can say that there are definite harms and risks associated with recreational cannabis use, especially when it's excessive, especially when it happens at a young age, right? And I don't think there's many doctors who would argue with that, or many scientists who would argue with that. It becomes a question of what do you do about it? Because if you try to ban it, I'm not sure it works. I think if there's a lesson that was drawn away from Prohibition, that you actually have better control and less usage when you allow it and regulate it. So don't allow places to sell it to kids and really enforce that, right? Have good laws against, people using it, at work or driving a car where it's frankly dangerous. So you can do all of these things because if you're going to sort of crack down on cannabis, then why don't you crack down on alcohol more? Why don't you crack down on tobacco more? So it becomes a very complicated policy question. And here's the thing, in the end, I do agree with you. I think there are definite harms there. Like there's a lot of people who say things like, cannabis has cardiovascular benefits. I'm not sure that's true. When you look at the evidence.
Get to that right now.
Yeah. When you look at the evidence, I don't think you bear that out. And there was a very famous example of Kevin Smith when he had his heart attack. He went on the Colbert Show and he went on this thing and he was like, my doctor told me that the fact that I was smoking cannabis had saved my life. I mean, that was certainly not true. And I'm pretty sure his doctor never told him that, or at least not in those words. But if you're going to make the claim that cannabis is good for your heart, I don't think that's true. If you're going to make the claim that cannabis is potentially problematic, I think that's closer to the truth. I think there's some uncertainty. But that's the scientific question. What's the policy response? And that I don't think we know. And I think if you tried to do a ban, it would be problematic. I think you get around it by regulating it. And I think the thing that's been the most successful here is having it sold by regulated dispensaries rather than people just selling it at the corner store. In the same way that you can't just go to a store and buy alcohol, you need a liquor license, So there's ways to regulate these things. You just have to regulate them and you have to be willing to put the regulation into place.
I think what my point here is that I agree, don't ban it. It's not going to, but I think maybe now that you're talking, they should have just cut and paste all of the public health messaging around tobacco and alcohol and cut and paste it over into all the cannabis stuff. It should be right there at the ads. This is not proven. This is really probably not great for you. You can do what you want, but don't believe this and people are getting information from the sellers. They're not really getting, I mean, the store should say this product is harmful. This, when you walk in this store, this person's a salesperson. They're not a health professional. We're never going to get that because the enthusiasm is just so great for it. But yeah, they should have just cut. It's going to take a while for the public health messaging to catch up. But I think I totally agree. When I was a kid, there's no doubt that the cigarette smoking ads, that the, whatever that national, I can't remember the name of it. They put out all those public service announcements about smoking. It had an effect. There's no doubt about it. It's way down. So I guess cannabis is just like coming out the opposite end of a funnel, if that's a way to put it.
Yeah, and I think, here's the thing. I think the public health messaging is going to catch up. I think we are going to get to a point. I think what's also interesting is that the minute you have decriminalization and legalization, a lot of the more outrageous claims about the health benefits of cannabis tend to go away. Like, you don't hear people talking about how cannabis can treat glaucoma as much anymore, because it's not true. It can't. Like, when you actually delve into the studies, and I think we talked about this during the episode with Mark Ware, I can't remember, it's actually not a good treatment for glaucoma. There are much better treatments for glaucoma. In the initial studies, it was like a temporary decrease in the eye pressure. So it's not true. But the minute you give people an avenue to enjoy the product recreationally, they stop trying to push the medical claims, which are unsupported by science. And a good analogy, again, goes back to prohibition. You go back to prohibition in the US, one of the ways in which you could get alcohol was with a doctor's prescription. So a lot of patients would go to their doctors to get a prescription for alcohol to treat their nerves or for stress. And then the minute prohibition ended, that stopped. So if we want to have good evidence-based use of cannabis as a medical product, ironically, allowing the recreational use in some sort of regulated fashion is actually going to make that easier, because it's going to take a lot of the hot air out of some of the claims, because the people who want access to it are not going to be using the medical claims as a justification to get access to what they want as a recreational product. So you will eventually stop hearing claims that cannabis treats cancer. It doesn't treat cancer. You can use it to treat the nausea associated with chemotherapy. And so I think that's where the future is going to go, where you're going to have the real medical claims and the people who were using the medical claims as a justification to get access to it in a setup where it was not accessible recreationally. I think those people are just going to sort of leave the conversation, and that's going to make the conversation a little bit more evidence-based. I hope that's what the future holds.
Okay, great. I think we're mostly in agreement here. So I just wanted to get some clarifying thoughts from you about all that stuff. Let's zoom in right into your wheelhouse, right? So we did have some specific papers. They were like, I'll put everything I had in the show notes that people can evaluate for themselves, but there were some specific things about cannabis use and cardiovascular outcomes. Mm-hmm. So let's talk about a couple of those. So I don't know how many there were that we emailed back and forth, like 3 of them, right? These are observational studies again, but it seems like the evidence on self-reported use in cardiovascular disease outcomes, not great. Yeah. I'll let you go.
Well, so here's the thing. When you do these types of surveys where you try to get information from people about their, habits regarding to cannabis, there does seem to be an association where there's actually more cardiovascular events in the people who consume cannabis rather than those who don't. Now, the big confounder here is that people who smoke cannabis are also more likely to smoke tobacco. So you need to be able to adjust for tobacco use to be certain. Now, you can do that, and of course these studies do that, but there's always the residual risk that you never adjusted for the smoking use completely. Now, this particular study, the one that we're talking about, Association of Cannabis Use with Cardiovascular Outcomes Among U.S. Adults, they did adjust for smoking. And what was good is that they also adjusted for a dose response. So because they were able to collect how much cannabis people were using, it wasn't just a yes-no thing. So the people who smoked more tended to have a higher cardiovascular risk, which leads credence to this. The big limitation with it, it's based on self-report. So you have to have that caveat in there. But it is suggestive that the risk is increased. With that, the secondary caveat is that it's always hard to tease out how much of that might be the coexistence of smoking in this population. And the researchers tried to address that, but you will never adjust for it fully unless you did a randomized controlled trial. But you will never get ethics approval to do a trial where you're trying to see if you can cause heart attacks in people. That would be very, very difficult to get past an ethics board.
And that study that we're talking about now is adults 18 to 74. So a huge range across more than half the U.S., right?
Yeah.
There's also some for people under 50, but in this one, they also did a separate analysis of non-tobacco but cannabis users, right? And so they still found the elevated risk.
Yeah, they did. Now, the study that you're referring to, again, it's a retrospective study. They were using electronic medical records, so it wasn't a patient cohort, so it wasn't a dedicated database for this particular study. They were just extracting data from the computer records when you went to go see your doctor. But it wasn't people less than 50, and they were looking for a diagnosis of cannabis use disorder. The issue with the medical record stuff is that, for people, when you're practicing medicine, you realize not every doctor enters every piece of information in the medical record. Sometimes you skip over, the data box if it's not really relevant. Like if somebody's coming in for a urinary tract infection, would you really record and ask them about cannabis use? I know, I will say this, that when I see medical records from the US, I am often shocked at how detailed they are. So I think in the US, maybe there's a little bit more sort of, I don't want to say attention to detail to make it seem like we're sort of shirking our responsibilities here in Canada. But there's always the danger that the electronic medical record is not going to fully capture everybody's cannabis use all the time. That being said, setting that aside, there was an increased risk of myocardial infarction with cannabis use, but that the absolute risk increase was very, very low. So the absolute risk increase went from 0.09% to 0.558%. So about a half a percentage point increase, which is not nothing when you apply it to a whole population, but it's not huge. So I think the correct extraction from this study is cannabis is probably not great for your heart. We have some asterisks and some caveats in there. It's probably not great. The absolute risk is pretty small, but it is something you have to be aware of. And I don't think the claims about cardiovascular benefit are founded in the evidence. I think when you look at the totality of the evidence, we say that there is a risk, but it's a small one in the absolute sense.
So this one we're talking about now, heart attack risk and cannabis use in people under 50. When you're talking about the absolute risk there, that is a small increase, absolutely. But in terms of risk ratio, you're talking like 6 times, right?
Yeah.
So is that, I know we have to say, I don't know, it's your chances, I can't remember what the absolute risk is something we have to consider, because if it goes from 1 in 100,000 to 5 in 100,000, sure, it's 5 times greater, but big deal, right?
Yeah.
I shouldn't be so callous about it.
No.
But in terms of a risk ratio of 6 times, or blood clots, they were like 430% higher, which is 4.3 times, and everything combined 3 times higher, right? Those are big numbers in terms of relative risks, right? Even though the absolute risk that's telling us something, right?
It's telling us something. It also depends on the population. So if you're, under the age of 50 with no cardiovascular risk factors, the risk it's posing to you is going to be relatively small. If you're an older individual with cardiovascular problems, high blood pressure, diabetes, obesity, you've had a heart attack in the past, your risk is going to be higher. So the relative risk is always going to depend on what your baseline risk is. So if your baseline risk is low, there's probably not much danger in cannabis triggering a heart attack. But if you have a number of problems and you're using it chronically, that small absolute risk can build up over time. So it's important to look at both. And it also becomes a question of are you worried about a public health problem, about sort of a tsunami of heart attacks once you legalize, or are you worried about the risk to the individual? And you have to think of both when you're doing public policy. But it's important also to differentiate them, because the answer is not necessarily the same in both situations.
Let me ask you something about that heart attack number that you just said, because this was from this paper specifically. This was something unbelievable. So it's actually literally unbelievable to me. I'm not sure how but they were saying that cannabis can precipitate a heart attack, particularly within 1 hour of consumption, with almost a 5-fold risk in young, healthy people. That just sounds like, I don't know. I mean, that's what they're saying. It didn't seem to, it just seems like an unbelievable number to me.
Well, here's the thing. I mean, if you remember the example that I used in the book about coffee, right? There was this one study about coffee causing a 50% increase in heart attacks in the first hour after you drink a cup of coffee because coffee is a stimulant. But then you translate that into an absolute sense. It takes 2 million cups of coffee to cause one heart attack. So numbers can always seem high, especially when you're thinking about it, because what is the actual risk that you're going to have a heart attack in the next 60 minutes? It's actually really low when you think that cardiovascular risk is often spread out over the course of a decade, if not several decades. So relative versus absolute risk is this really complex topic to wrap our heads around. And it's actually really hard for the human brain to process these like decimals of like 0.5 versus 0.09%. Like, what does that mean, right? It's not nothing, but it's not a major public health threat either. And that's how you have to sort of look at it. Like, are you saying that cannabis is good for you? No, I don't think it's good for you. But is it a public health threat? Probably not. And then you start thinking, it's like, well, are there certain groups that are more at risk? And that's where regulation comes in, and you can start being a little bit more circumspect about who you sell it to and when.
Also in that study, all-cause mortality was higher, but it came on the study that cannabis users were more likely, I think, like 15 times likely to have a prevalence of depressive disorders. So that made me wonder if like a large portion of those are self-medicating with cannabis, and the all-cause mortality may be higher due to, I hate to say it, but suicide among those users, right? So what's bumping those numbers up that is a confound, that's not cannabis?
Yeah, there's a lot. This is the problem with observational studies, right? The more you dig into them, the more you realize there are many, many caveats there. So we get back to the point that we kept saying is like, we'll never have perfect data. We have to make the best decisions with the data that we have. And, you say, okay, we have certain caveats. We'll probably never have a randomized controlled trial on cardiovascular outcomes with cannabis, not in the foreseeable future. What do we do with the information that we have, and how do we shape our public health messaging? And I think the answer to that is we tell people, look, it's probably not good for your heart. The risk is not high, but it's not beneficial. And so you start trying to counter some of the misinformation out there, because there are people who claim that cannabis can cure every disease under the sun. And that's not accurate. And, for the people who are real medical professionals, even people who use it and who are proponents of it, I think they also are not happy with this type of dialogue, because it undercuts their research where they're trying to use it in specific situations like pediatric seizures, like multiple sclerosis, like, cancer, chemotherapy-induced nausea. There are situations where it could have a real therapeutic use, but you get this reluctance on the part of patients to try it because they hear all this sort of crazy stuff online that is just not evidence-based.
All right, let's move on from cardiovascular disease to another thing that came up, the poisonings, overdoses. So this is edible cannabis legislation and cannabis poisonings in older adults. That's the name of the study. So I think this was a fairly easy study because it was emergency department visits due to accidental poisonings in older adults, 65 to 74. So there must be a number of, I'm sorry to laugh, but you don't think of my grandma going down the street and to her pot shop and, well, actually, this was accidental cannabis poisoning, so I guess it relates to my anecdotal story. But it was a fairly easy study because, it was looking at emergency department visits from 3 points in time: pre-legal, after legalization of dried cannabis, and then after legalization of edibles. All right, and so they were just looking at visits in the ED where they could get it coded for a cannabis poisoning. These numbers went up. I mean, the relative numbers went up. Right.
Yeah. Well, here's the thing. So this is from Toronto here in Canada. So we've been
Yay.
a great. Yeah, exactly. Well, the one good thing, well, not the one good thing, but one of the main good things to come from the legalization is it allowed people to actually collect data to look at, see what are the impacts of legalization in terms of accidents, overdoses, and all that, because we have all this data now in Canada. It's not giving us any information about efficacy, but it is allowing us to look at safety data, which is, like you said, relatively easier to collect. So this was done at the Sunnybrook Hospital, which is a hospital north of Toronto here in Canada. And so in Ontario, cannabis dried flowers were legalized in 2018. Edibles became legal in 2020. And so when you look at emergency room visits from the before, the middle, and the late period, ER visits did go up. Now, there were in total 2,322 emergency room visits over a span of 8 years, which was the study period. So it's a lot for one hospital in Toronto, which has many hospitals, but it is spread out over a long period of time. So there hasn't been, again, a deluge of emergency room visits. And anytime you have a product, there are going to be accidental poisonings, right? People are people, they make mistakes, they take too much, they confuse stuff. It happens, right? The unfortunate reality is that older patients, especially patients with dementia, they sometimes make mistakes. They double take their medication. Like, it is not a rare occurrence. So when they examined these patients, about 16% of them also had alcohol intoxication. So it looks as if they were consuming multiple products that led to problems. About a third of them had cancer, so they were probably taking it as part of, the chemotherapy stuff that we talked about. And about 6% had dementia. So you think accidental, a lot of this may have been as a consequence of dementia, which is not going to be relevant for, young people who otherwise don't have this. So to get into the numbers, yeah, it was a tripling of ER visits, but it went from 5.8 to 15.4 ER visits per 100,000 person years. So again, a tripling of the risk from the relative standpoint, but in the absolute sense, a small bump, all things considered. And so this is the issue that we have. Yes, you're going to see an increase in ER visits, but it's going to be a pretty small increase if these numbers can be translated out large. Some caveats: this study was done, remember, 2020, this was done during COVID after that, so COVID disrupted many things, so maybe things would be different in a non-pandemic setting. But, anytime you legalize something, there's always going to be more overdoses right away because people are unused to a product. The presumption is that if there was this increase, that's probably going to level off and go down long term as sort of the initial confusion, if you will, sort of settles with time.
Okay, well, that's optimistic, I guess. Let's hope for that as more education as well. I think also, you never know. These it's like I'll call it a supplement for right now. If you go get your edible cookie or your brownie or whatever, or your chocolate bar, I'll call it a supplement for the same reason that you don't know about interactions with other medications in these older people, I assume.
Yep. Yeah, that's a problem. That's an issue, right? It's not a benign substance. So yeah, medication interactions they are a real thing. That's absolutely true.
And then I think this came out in the study also that there's also the ride it out factor. There may be people that just ride out their distress.
Yeah.
So they're not captured. So, but if they ride it out, at least that's not a societal cost, I guess.
Exactly.
Overall, I mean, I'm still skeptical, and I would just like to see the public health messaging greatly increased, like notched up 475%, just like the ED visits up there.
Yeah, I think we have a big challenge here. And I think the biggest challenge is going to be in the messaging, but also in regulation, about making sure people do not buy illegal cannabis products, that what they're buying is a standardized dose. They know exactly what they're getting. Just to throw you a caveat, remember a few years back where there were all these lung disease cases because of teens who were vaping cannabis and they were getting these packets from China that had been contaminated with the substance and it was causing like a specific form of lung disease. This is a problem, right? So if you're going to consume a product, you need good quality control. You need to make sure that if you're buying 10 milligrams of something, you know it's 10 milligrams of something. We know we shouldn't be selling it to children. We know that people shouldn't be using it before they operate a motor vehicle. That's where we really need to hammer home the messaging. And I think we've been a little bit slow off the mark to do that. But I think we need to do that because there's two different conversations happening. There's the recreational use and the public policy about messaging and about safety. And then there's the medical uses that are being done in hospitals and academic centers and research institutions. That, I think, is proceeding pretty well. I think we're getting a much better idea of what we can use cannabis for and what we can't. So I think it's pretty clear that this whole glaucoma thing is not true. I think it is like the best evidence is really for the pediatric seizure disorders where you have, multiple randomized controlled trials where nobody argues with its effectiveness, but it is using a very, very specific dose of a synthetic CBD preparation or a synthetic THC preparation, depending on the study. So we can use this medically, we can tolerate it recreationally, and we have to realize that these are two separate things where one really shouldn't affect the other. We can do one, we can regulate the other, and I think that's how we have to think about it and proceed going forward.
I would like that health messaging to get into schools on the bulletin boards like crazy because the the cannabis hyperemesis syndrome, the screaming nausea, has risen like from a couple times a month to 5 times a day. That is a total waste of money that could easily be prevented by, if you're going to eat an edible, don't expect the effect within 15 minutes, so you eat another one. Don't do that. I mean, I'm not sure.
Yeah.
Nobody's going to listen to me, though. You need to see this billboard or this poster in a school, because
You-
when I'm
you need
talking
to-
about
yeah.
hyperemesis syndrome, we're talking like these studies are in kids from like 5 to 21. The median age is like 17 or something. These emergency department visits are something that could be totally avoided. Huge cost, not only to the patient, but it's the resources and the parents that have to go. And I mean, there's all those spiraling costs. So we got to get that messaging out there.
Yeah, and the other thing too is with parents, like for very young kids, let's assume that kids are not going to their local like dispensary to get cannabis on their own, right? They're consuming stuff they're finding lying around the house. So if you're a parent, make sure that your detergent pods are out of the reach of children, and make sure your medication is out of the reach of children, whether it's recreational or medicinal cannabis, right? So you have to educate parents to protect the young kids. When they start to become teenagers, you got to talk to them in schools and tell them like, look, this is what cannabis, in the same way that we talk to them about alcohol, right? We go into it understanding that kids are probably going to try alcohol, that they are probably going to try or at least be exposed to smoking, and speak to them about the harms and benefits and all the stuff that you mentioned. If you're going to do an edible, don't eat 2. It's meant to be 1. Like there's a reason for that, So many people make that mistake, but that's an education thing. So we need to do that. And then for the adults, it's really got to be about regulation and, selling it in approved places. The minute you commercialize something, it becomes much harder to control it. And that's where I think there's, more of a problem in that, selling it in government dispensaries at least controls that. And that's sort of the approach that was taken here in Canada.
Let me also make another point. I may be the victim of availability bias here, because now that it's recreational use is legal, this has probably been, you're an epidemiology professor, this has been a boon for anybody seeking a master's degree in epidemiology or a PhD. I mean, it's like a whole new thing you can study. And I have like 50 papers on how horrible these things are, from observational studies, of course. Yeah. But it's like, I'm getting these things once or twice a week now. And so this availability of the information is like, holy cow, we're falling off a cliff here.
You also have to be careful of people who keep reanalyzing the same types of data over and over again. Like, we have enough papers to show that ER visits go up. At a certain point, we don't need more of those. We understand, like, overdoses happen, right? You make something available, overdoses will happen. It's pretty clear. The solution now is like, what do you do about it? How do you prevent these overdoses? And you have to behave differently if your issue is overdoses in kids, overdoses in teens, or overdoses in adults, right? Those are different phenomena that need to be addressed. We don't need to keep rehashing the same issue and going back to the same well to draw the same water again. We know ER visits go up. We've seen that in Canada. We've seen it in the US. It's pretty clear. It's I think, as settled an issue as it possibly can be.
Okay, on a completely separate note, or a couple of separate notes if you have time, you are producing a body of evidence episode a week. Wow. Yes. What? Yeah. And everything else I said in your bio, plus you're trying to work on a sequel for a book. What? What?
It's tough. I'm not going to lie to you. It's tough. Yeah. So we do weekly episodes now. We used to have a monthly podcast. Now we're doing it weekly. It's all about timing. You surround yourself with good people and you make it happen. I mean, I have a great team on the podcast. I have Robin Flynn as our editor. She handles all of this. She handles all the back end stuff, which is great. I have a great partner on the podcast, Sophie, who's a master's student now, and she's great to bounce ideas off of. We have, regular guests that come on. It's fun. It's a lot of time. It's a lot of work. It doesn't pay nearly as well as it should. But it's a fun thing to do. And, I harken back to the old adage, like, if you love what you do, you never have to work a day in your life. So I do things that bring me intellectual joy. And it's not that bad. Like, speaking to you has brought me intellectual joy. So I was more than willing to give up, an hour plus time, amount of time just to chat with you and talk about this issue.
Well, I appreciate that because I feel smarter now. So it brought me into, I'm not sure that's the case, but at least I feel a little bit smarter. So, I guess hosting this episode is observationally beneficial to my well-being. The last thing, any updates on the sequel to Does Coffee Cause Cancer? We got to find out what's going on in that love situation.
I have it all mapped out. I haven't sat down to write it yet. What I'm actually thinking of doing, a friend of mine, Natalia Pasternak?
I do, yes.
Yeah. So she started a series with Columbia University Press, being What the Science Says About Blank. And so the first book of that is about to come out. It's like What the Science Says About Astrology. So it's sort of like a debunking astrology. And so she asked me, would I write a book about cholesterol? So what the science says about cholesterol. So they're going to be sort of like shorter books. And I've kind of already written about this a lot. So I'm like, oh, okay, maybe I'll tackle that first. And then as that goes to press, then I'll start on the sequel book. So the sequel there is in my mind. Now with the wedding and the house purchase behind me, I think I have more free time and I think I'm going to try to tackle it. But that is on the horizon. For people who are following the story of the unnamed narrator and Casey and their dog Rufus, I think we need to see how it pans out. What I love to tell people is that everybody thinks that the character of Casey is based on my wife. I actually met my wife after I finished writing the book, but before it got published. So it's really shocking how, a wife and a doggo came into my life after writing the book. It really is a perfect example of life imitating art.
Yeah, you may just have to start saying, yeah, it's her. Because I remember my wife was in a jazz band called Joy Spring.
Yeah.
So people thought that was her name because she was the leader of the band. No, my name is not Joy Spring. That's a title of a song we used to name the group. No, but eventually just say, yeah, okay, great, nice to meet you.
Absolutely. Based on her, absolutely.
Joy Spring, great. It's a good story. So I'll be interested in that book series because those will be like little mini reader books, like you can read them in an hour or something.
Yeah, probably.
Like some of those little minute philosophy books or whatever or hour books. I can't remember. Yeah. There's a whole series of books like that on things. So, all right, Dr. Christopher Labos, as always, I greatly appreciate your time. It was great to speak to you. We did meet in person, I don't know, maybe a year and a half ago at one of your book readings. That was fun.
Yeah.
I met Kelly. Anyway, Dr. Christopher Labos, once again, thank you so much for being here. Your book is Does Coffee Cause Cancer? You write for the Montreal Gazette. You have the Body of Evidence podcast. You are easily available with a Google search as long as you spell your name correctly. So,
exactly.
And thanks for all the good work you do. I know the writing doesn't pay as much as you're saying, but you're reaching a lot of people, I think. So, unlike me, you are. So I appreciate you taking the time to come on my show here. So,
my pleasure, Brian. Anytime.
Thank you so much.
Take care.